Lee. Hello, everyone. My name is Seok Soo. I am research professor in Department of Nuclear Medicine, Seoul National University Hospital. So following the lecture from the previous lecture of lung cancer, today what I would like to discuss is about the gastrointestinal tumor, and I will cover the stomach cancer and the colon cancer. And actually, as I am also not an clinical expert or radiologist, which are experts in reading the images, but I think I would like to share my experience or opinion and the recent reviews. So I think there might be more better experts here who is listening. So if you can share us some more experiences, I think it is always welcome. And in between the lecture, if you have any questions, please write down at the chat, and then we can have some time for the discussion. Okay, nice to see you all. And okay, so the contents will be stomach cancer and the colon cancer today. So the stomach cancer is a fifth most diagnosed malignancy worldwide, and it's a third most common cause of cancer-related deaths. And actually the incidence, as you can see in this map, the incidence is high among East Asian and East Europe, and also South America. So like in Korea and Japan, there are quite a lot of cohort of patients which are suffering from stomach cancer. Before starting, we need to actually know the definition of the stomach cancer. And actually, it has changed from the Ajcc 8th edition. So previously, the margin was 5 centimeter, as you can see here. So but however, it has changed to 2 centimeter. So if the center of the tumor is within 2 centimeter of the esophageal gastric junction, and if it invades the esophageal gastric junction, it is not a stomach cancer, but it is classified as a esophageal cancer. But in other case, like if the center of the tumor is more over 2 centimeter of the EGJ junction, and if it does not, although it is within the 2 centimeter, if it does not invade the EGJ, it is classified as a stomach cancer. And the stomach wall is composed of 5 layers, which is lamina propria and muscularis and mucosa, submucosa, and muscularis propria and subserosa and serosa. And when you see by the ultra endoscopy ultrasono, you can see 5 layers as in the picture, as the most inner layer, which is the mucosa, and the second as submucosa, and following is muscular layer and subserosa and serosa. And however, from the multi-detector contrast enhanced CT, not like the histological or like in the endoscopy, only 3 layers of the stomach walls are actually discernible. So these 3 layers are at the innermost is the mucosa layer, and in the contrast enhanced CT, it shows with a high intensity. And following at the middle side is the submucosa layer, which has a quite low intensity compared with other mucosa layer or muscle and subserosal layer at the outer surface. And normally the thickness of the gastric wall is known to be 5 millimeter when it is adequately distended using like waters. And however, it can have a range in between like 5 to 10, and when like it is under distended, the clinicians think like the thickness, normal thickness, can extend to 1 centimeter. So, however, when these wall thickening actually exceeds these normal threshold, the clinician, the radiologist or clinician can think it as a suggestive of malignancy. So, in some institutes, like when there is a wall thickening exceeding 1.5 centimeter, it has a high prevalence of a malignancy. Still, it is important to note that a mass-like appearance is actually often seen at the gastroesophageal junction because of the oblique course of this distal esophagus. So although it exceeds like 1.5 centimeter, it might be frequently seen in this upper part, and if it is not well distended. So regarding these gastric wall, the T stage is actually defined. So this is the recent, the 8th edition of Ajcc T staging. And as you can see, it contains of T1, T2, T3, and T4. And for T4B, it is defined as tumor when it invades adjacent structures. And these adjacent structure actually are like spleen, transverse colon, liver, and diaphragm, which is close to the gastric wall. So more specifically, if we see some examples, so the T1A is tumor which invades the lamina propria or muscularis mucosa layer of the gastric wall. And in the CT contrast enhanced CT, T1A actually is not depicted, and it's not actually discernible. Just a small, some hint of mucosal enhancement can be seen. However, or mucosal thickening can be seen, but it's not well discernible in the CT imaging. So endoscopy must be used to actually see this T1A. And T1B is when the tumor invades the submucosal layer. And in the CT image, you can see a enhancing mucosal thickening with intact low attenuation strip. So the outer layer of the gastric wall is actually intact in this T1B. If you move on to T2, as you can see, it is a tumor which invades the muscle layer of the stomach wall. So you can see that it actually destroys this low attenuation strip. But also because it does not penetrate through the peritoneum, the outer layer of the gastric wall is smooth in the CT finding. And for T3, it is a tumor which penetrates subserosal connective tissue. And you can see the whole gastric wall, so transmural thickening of the gastric wall and transmural enhancement in the enhanced CT. However, also it does not like penetrates the outermost peritoneum of the stomach. So the usually the outer surface of the gastric wall are mostly smooth in T3. However, when there is a T4, if there is a serosa like visceral peritoneum invasion, you can see with the transmural thickening, you can also see a irregular or nodular outer border and also perigastric fat infiltration. Okay, so beside this gastric wall, there is also a gastric ligament. So the subperitoneal space is actually a continuous interconnecting space beneath the peritoneum, and it contains the ligament, mesenteries, and suspended abdominal organs. And it has a interconnection. So because of this interconnection, these gastric ligaments can serve as a route for tumor spread. So for the gastrohepatic ligament, GHL, can spread to hepatic lobe by cross from the cardia and like lesser curvature of stomach to the left hepatic lobe. And hepatoduodenal ligament, HDL, can serve as a route to spread from the anterior antrum of the stomach to the pancreatic head. And also this gastrocolic ligament as named, and like gastrosplenic ligament as named, it goes to transverse colon and spleen respectively. And the splenorenal ligament, the SRL, usually spread to the left side of the abdominal cavity, and it can be a route for invasion of stomach cancer to pancreatic tail or descending colon. So whenever you interpret a stomach cancer image, you need to always be in mind the location of the center of the tumor, whether it is in the upper part, or whether it is in the lower part, or in the middle. And actually, later on, I will discuss, but these three portions are also important for the lymph node metastasis and lymph node spread. So because of these ligaments or interconnection between the spaces, this gastric cancer, after penetrating the peritoneum, can actually invade adjacent structures. So like in the CT scan, you can see a wide obliteration of the fat plane between gastric tumor and adjacent organ. In this case, the gastric tumor and the pancreas has a obliteration. And actually what you can check is the lower image is the right decubitus position of image. And like if there is a harsh adhesion, obliteration, the stomach may not move. So there is a negative of the sliding sign, which might be the, which may reflect the invasion and adhesion. And as discussed previously, this in this case, like the pancreatic invasion may be through the hepatoduodenal ligament and the tumor, which is in the proximal, so the lower part of the stomach. And next is the lymph node. So there are like Japanese guidelines to designate lymph node stations. And what we need to be in mind is how they differ the regional and the distant metastatic nodules. So the regional lymph nodes are is composed of 12 lymph nodes, which is in this table. And the 6 lymph nodes are actually indicated as a perigastric lymph node. And I will discuss later on, but this regional and other regionals are actually discriminated because it has a different surgical indication. So in the surgery, for the D1 dissection, usually the perigastric lymph nodes are dissected, but when it is extended to the D2 dissection of the lymph node, these regional lymph node dissection extends to this other regional lymph nodes up to like this 12 station of nodes. And if the lymph nodes are visualized in this distant part, it can be, it is regarded as a M stage and the metastasis. And usually this naming of the lymph node stations are following the tract of the artery that this lymph node follows. So like left gastric artery or celiac artery, you can imagine and you can find the lymph nodes relevant to their location of the arterial anatomy. And also, as explained previously, the location of the tumor is important. So for like lesser curvature or greater curvature, like this perigastric lymph node, it is actually, it can be involved regardless of the tumor location. However, tumors in the upper third, like in the upper portion, are more likely to spread through pericardial or celiac or splenic hilar or splenic artery lymph nodes. And tumors in the lower part are more frequently involve the common hepatic artery or supramesenteric vein. And tumors in the middle actually can go in the upper or the lower part to the either side. So for more specifically, you can see some lymph node station, and this left pericardial, which is the regional regional lymph node, is located on the left side of cardia along the cardio-esophageal branch of the left inferior phrenic vessel. And the right pericardial lymph nodes are, as named, located on the right side of the cardia of the stomach. And the splenic hilum lymph nodes are located at the splenic hilum, the start to end of the pancreatic tail. And the lesser curvature lymph nodes are located along the descending branch of the left gastric artery and along the right gastric artery. And this hepatoduodenal ligament lymph nodes are located along this hepatoduodenal ligament, and it actually includes 3 separate groups, as like whether the lymph node is in the left side of the duodenal ligament or in the posterior side of the duodenal ligament. And there are also perigastric lymph node, which is suprapyloric lymph node, that are located at the lesser curvature immediately above the pylorus, and infrapyloric lymph nodes that are located at the greater curvature and below the pylorus. And also the pancreatic lymph nodes are located along the pancreatico-duodenalis and the superior anterior vessels. Another lymph node, which is named lymph node station, which is named following the arteries or vessel, they actually followed the tract of these vessels, so you can easily If you can localize the vessel, you can actually easily name the lymph node. So this is the recent Ajcc for nodal staging, and the importance is the number of the metastasis, which actually is relevant to the prognosis. And for the CT image, there are like different reading criteria, but normally, like usually, they indicate the positive lymph node ad, which has a more longer diameter of more than 8 millimeter in the short diameter, and when there is a perilesional, like more than 3 perilesional nodes, and if there is a like strong enhancement or necrosis, we can refer it as, or it may be more indicated of metastatic lymph node. Okay, and for the M staging, the most frequent site of the stomach metastasis is actually the liver, and followed by is the peritoneum, lung, and bone. And because the venous from or lymphatic from the stomach are collected through the liver may be the most frequent site of the metastasis. And this is a brief table of the Ajcc staging, how the staging works in the Ajcc. So we have reviewed some the anatomy of the stomach cancer, and the relevant staging workup, how staging is done in the stomach cancer. So now I would like to introduce about the role of the Fdg PET-CT. But before that, I would like to show some Fdg uptake pattern in the stomach cancer evaluation. So firstly, the anatomy can have an effect in the Fdg uptake pattern. So this is about the physiologic uptake in the stomach. So usually the physiologic uptake in the stomach is higher in the upper third portion. And when it goes down to lower portion, the SUV or visual score, as you can see in the figure, gets lower. So tumors, which is like if there is a focal uptake in the middle or the lower part of the stomach, it may be more indicative of a malignant or tumorous condition. But however, if the focal, like this uptake is in the upper portion of the stomach, it may be hard to distinguish between whether it is the tumor or whether it is a physiologic uptake of the stomach. But there is actually not that much information whether the tumor uptake is associated with the location. It's actually not relevant right now. But there are known factors that are related with the tumor Fdg uptake. So firstly, I would like to introduce the histology. So stomach cancer can be discriminated by the histology findings, like lowering classification actually discriminates the stomach cancer as an intestinal type or diffuse type or mixed. And WHO or Japanese classification can classify as a papillary or mucinous condition or like signet ring cell part. So there has been studies how the FDG uptake are related with these histological findings. So this study have shown that this SUV or FDG uptake of the gastric cancers are higher. Sorry, yeah, is higher in like moderate differentiated and compared to the poorly differentiated. And also it is like higher. It is very low in the signet rings if there is a signet ring cell component. And according to the Lauren classification, intestinal type shows more higher FDG uptake compared to the diffuse type. And also what you need to see is that these uptakes are actually related with the size of the tumor. So as assumed that bigger size of the tumor may reflect higher FDG or SUVs. So like in the case, you can see that like patient, although it has similar wall thickening, if it has a histological type of Lauren classification as intestinal growth pattern, it has this kind of high FDG uptake usually. But for the patient which has a diffuse growth pattern, like poorly cohesive carcinoma or like with the signet ring cell components, it has relatively low FDG uptake. So these are some normally known FDG ability according to the histology. So like low FDG ability tumors may have characteristics of mucinous or signet ring cell component, or whether it's diffuse or like Borman type 4 or poorly differentiated have low, usually have low FDG ability. And these tubular or intestinal types have high FDG ability. So to actually, when you read like, or you know, like when you read a this FDG PET image in the like to find the recurrence, or when you do it for staging after the biopsy, the thing you should think in mind is the characteristic, like this histological characteristic should be in mind because it has a significant effect in the FDG uptake. And recently, there has been a great change in the paradigm of the gastric cancer subtypes. So like in the past, like these histological classification might have been important. However, there is a growing interest to subtype this gastric cancers according to the genetic factors. And so these are some key features of the gastric cancer subtypes, like which is EVB positive, or which has a microsatellite instability, or which has a genetic stability compared to like other EBV or MSI. And these are quite distinct. The subtypes are now showing quite distinct prognosis and characteristics. So for the EBV, there has been some studies to find out the relationship between this genetic subtype, like genetic alteration, and how it is related to this FDG uptake. And for the EBV associated gastric tumor, it is this study have shown that EBV associated, like EBV positive gastric cancers has a high as FDG uptake. However, the reason why actually is right now not that clear, and it is unknown. However, like one possible explanation could be the dysregulation of the metabolic signaling pathway. And like previous studies have shown that the PIK3CA signaling pathway is actually mutated in this EBV positive gastric cancer, and this PIK3 which is very relevant to the Fdg uptake. And next is there has been one study that has shown the relevance between this microsatellite instability and the Fdg uptake. So this study have shown that there might be a link. There has some higher Fdg uptake in the patient with the microsatellite instability. And they explain that it might be related with the glucolytic activity of the inflammation in this gastric tumors. So like this, because the microsatellite instability actually is relevant to the inflammatory cell infiltration in the tumor. So if there is large portion of these infiltrating inflammatory cells, they suspect that there might be higher Fdg uptake. But however, these studies there are not that many studies regarding genetic change or genetic mutation and its relationship with the Fdg uptake. So we cannot easily conclude how these subtypes will be relevant to the Fdg uptake. So the NCCN guideline actually indicates the Fdg capacity for the workshop when like if it is clinically indicated and if there is no clear evidence of the metastatic disease. So like it is actually not recommended in the patient which has a clear metastatic distant metastasis. However, like patient which is suspicious or which needs to see the distant metastasis, or like patient who contrast CT cannot be done. In that case, NCCN guideline actually recommends this Fdg PET-CT for workup. So I will show you some cases which have been done in the scenario of the workup for the stomach cancer. So the first case is a 52-year-old male patient has come to the referred for the abdominal discomfort. And in the previous EGD in the outside hospital, they had concluded, they have said there is a gastric ulcer, so they gave the patient a medication. However, after the medication, like 6 months of medication, this abdominal discomfort didn't go well. So this patient went again for the EGD, and the patient had found gastric cancer. So this is the PET actually it has been done to see whether there are like distant metastasis or for the purpose of the staging. So, okay, we can. So there are some actually it's not a lung view, but there is some diffuse hypermetabolism. And actually in the CT scan, there was a infiltration, which can be referred as a inflammatory process in the lung field. However, in the stomach, we have done the protocol as using the distension protocol. However, as you can see, there is no discernible focal hypometabolism suggesting a stomach cancer in this patient. And okay. However, like as you can see, there is a prominent thickening in the enhanced CT scan. And when compared, looking at the CT and compare to the referring site in the PET, there is a very mild Fdg uptake in the site. And the SUV max was 2.3 in this site. And after, so this patient underwent a gastrectomy, and this patient was proven as a poorly cohesive carcinoma, which is as from the Laurent type, which is a diffuse type. And the second case is a 72-year-old male patient, also has come with a abdominal discomfort. And after the EGD, the patient was diagnosed as gastric cancer. And you may see from the image that there is some reactive lymph nodes in the mediastinum, like the hilar areas. However, we concluded as a reactive lymph node. And from the gastric image, actually there is some flaw that the, as you can see in the liver, the PET and the CT registration was not well done in this study. So the stomach uptake actually in the MIP image actually is quite well seen. However, in the transaxial image, it might not be that much discernible in this transaxial image. But what you can see is some perigastric lymph nodes and also retroperitoneal lymph nodes. So I actually have done again for the registration, and as you can see, there is a quite high uptake, which the SUV max was 6.8, and also lymph nodes with a Fdg uptake was also visualized in. So there, the patient was in clinically, we could have diagnosed as a stomach cancer with regional lymph node metastasis. And also, if you see there in the CT scans, you can see some retroperitoneal lymph nodes and also some, clusters of perigastric and gastrocolic lymph nodes. Like this is our infrapyloric lymph nodes. And as you can see, it is very indicatable of the metastatic lymph nodes since it has a necrosis. And also they are like clusters, like 3 or more lymph nodes are clustered. Okay, so this patient underwent a proximal gastrectomy, and it was found to have a tubular adenocarcinoma with a moderately differentiation, and the involvement was at the lower third of the stomach. So you can imagine this patient will have more. So you need to actually have more careful look in the lymph nodes in the infrapyloric, or which is along the superior mesenteric artery. Lymph nodes should be more carefully seen as it is in the lower third antrum portion. And as you can see also that the histological type was intestinal and moderately differentiated and tubular. So we also can imagine, compared to the poorly cohesive carcinomas, this gastric cancer might have a higher, it is relevant to see higher Fdg uptake in this kind of case. So for the T staging, the Fdg PET, although it has a very high specificity, but because of its relatively low sensitivity, it is not. It has a limited role compared to the contrast enhanced CT. And actually, when it goes to actually, it has a high detection, its accuracy or its ability when it's applied to the advanced gastric cancer, but it really drops in the early gastric cancer. So it has a somewhat limited role for the T staging. However, like some strategy can be applied, like this study actually have done a distension, gastric distension using a water, and they have shown that there is a higher specificity or higher positive predictive value. So which as a result showed a higher accuracy. And actually, when you do this distension, the thing why you can earn this higher accuracy is that it actually can result as a higher tumor to background normal stomach ratio. It's higher when you give a distension. And for the nodal staging, the Fdg PET is actually limited in the detection of the regional, very perigastric lymph node. Yeah, sorry. So the sensitivity in this local regional lymph node is actually higher in the CT. However, actually in the clinical, for when you think about the clinical impact, since like most case, the D2 dissection is done, so the high detection rate for local regional lymph node metastasis might not have that much high clinical impact, or well, it can actually like change the course or change the strategy for the patient is actually not that much. But actually for the like N2 or like tier 2 or like more distant metastasis, it is actually important to characterize these lymph nodes. And PET has in like meta-analysis, they have shown that PET has a similar diagnostic performance compared to the CT, but higher specificity, like more than 90%. So because of these high specificity, PET-CT can play an important role in extending the degree of the lymphadenectomy or reducing the other futile laparotomies. So this is a proposed Japanese gastric cancer, the treatment algorithm of the gastric cancer. So in most cases, when there is like more than T1 clinically, if there is like, if it's more than clinically T2 higher than T1, so usually the patients are done as a D2 dissection of the lymph node. And only in the limited cases of like T1 or B with no lymph node regional lymph node metastasis, D1 can be done. However, if like PET can actually find some like tier 2 or other lymph nodes, the strategy for the patient treatment can change. And about the D1 and D2, actually it is not like always same, but it is actually different according to the extent of the gastrectomy. So usually, but the D1 dissection is dissecting the perigastric lymph nodes, and D2 actually extends the dissection to the second tier lymph nodes, like which we have seen from the previous nodal station. So in just a brief summary, like nodal staging in the perigastric area might not be that much important to change the clinical course of the patient. However, to detect the second tier or other distant lymph node is important, and FDG PET might have some role in detecting those lymph nodes. And actually, this lymph node uptake is has a high correlation with the primary tumor itself. And actually, when the SUV of the primary tumor gets higher, as you can see that the diagnostic performance to detect the lymph node metastasis gets higher, and there is a significant difference compared to the low SUV group, low primary SUV compared to the high primary SUV. So you can imagine that the characteristics also of this primary tumor is also important for the detection of the lymph node metastasis. And for the M staging, the PET-CT has some, it can be divided into the peritoneal seeding or to detect occult metastasis. So for the peritoneal seeding, there is still a debate between what might be the better strategy. But usually it is known that CT has a higher sensitivity to detect peritoneal seeding, and the PET has a higher specificity compared to the CT. And for the occult metastasis in this advanced gastric cancer, it is reported that there has been more than 10% of patients in the scenario of advanced gastric cancer. They have found occult metastasis in the FDG PET-CT. So actually, it resulted as a cost saving of $13,000 per patient. So PET-CT may play an important role in changing the treatment strategy, and actually it can result in the cost saving for the patient. And to actually understand the peritoneal seeding, or we need to know the anatomy of the peritoneal cavity. And this peritoneal cavity is divided into several anatomic compartments by the ligaments and the mesentery. So firstly, the cavity can be divided into the superior mesocolic and inferior mesocolic. So the superior mesocolic actually this right phrenic or subhepatic space or left subphrenic are in the supramesocolic compartment, and these lower parts are in the inframesocolic compartment. And the importance is there is a fluid movement, and there is some normally there is a flow in the peritoneal cavity, and this fluid flow can have a can affect the location of the peritoneal seeding. So it should be importantly seen. So usually for ascending colon cancer, it might have a higher relevance to have a peritoneal seeding in the subhepatic or light subphrenic areas. However, for descending colon cancers, it might have a seeding along the left inframesocolic space or along the left paracolic gutter. Do you have? Okay, so there are like some frequent location where peritoneal seedings occur, but actually you need to know that it is different according to the primary tumor and the location of the primary tumor. But however, because of some location, there are some frequent locations like peritoneal reflection or lower small bowel mesentery or sigmoid mesocolon or right paracolic gutter, right subphrenic space or greater omentum. So when you interpret like gastric cancer or like cancer which is suspicious of peritoneal seeding, these places should be more careful to see. Okay, so and also this study actually recent study has shown the role of the FDG PET, and as previously mentioned that the FDG PET actually can have a role for changing the strategy, and in this case they have found like 19% of patients in the advanced gastric cancer has a upstage, and actually among these 20 patients which has been upstage, 17. So most of the patient had no evidence on other imaging, which is quite significant. But one more thing that you should actually look from this result is that like there is more chance of to check like the more chance of upstage to be detected like in the intestinal type. So there also is a relation between the metastasis and the primary tumor characteristics or primary tumor SUV uptake. So when you are reading the FDG PET for the stomach cancer, you always have to be in mind of the primary tumor and the characteristic. So like in this case, the patient had a signet ring cell component of tumor, and as expected, the primary tumor has a low FDG uptake, and also the seeding lesion from this patient in the paracolic gutter also have shown similarly low FDG uptake, which actually can limit the detection of the metastasis. So moving on to the next case is actually in the scenario of the recurrence evaluation. So 70-year-old male patient had a advanced gastric cancer, and 3 years ago, he underwent laparoscopic distal gastrectomy. And pathology was found to be tubular adenocarcinoma with moderate differentiation and Laurent type of intestinal type. And 3 years later, in the CT regular follow-up, the patient had been found with a suspicious lymph node in the CT. So this patient had moved on to get more to characterize this lesion using the FDG PET. And I think you might have seen that there is a like with the SUV uptake of 5.3, there has been a mesenteric lymph node, which was visualized with a high FDG uptake. So we can expect, since the primary tumor had a characteristics of like intestinal type or tubular, so we can also imagine that this recurrence recurred lesion may also have a high FDG uptake. So we could have defined this and indicated as a metastatic lymph node. So the patient underwent omentectomy and lymph node dissection, and it has been found out to be a metastatic adenocarcinoma. So for the recurrence evaluation, FDG PET has a pooled, there has been many studies regarding, and from the meta-analysis, the pooled sensitivity and specificity was 85% and 78% respectively to define the recurrence. And also, since the recurrence mostly occur in the leftover portion of the stomach or at the anastomosis site, so like gastric distension or a delayed image can help diagnosis. So like when you do the delayed image, it may help. So when you see like in this case, like before the distension, you can see a high uptake in the upper part. So this patient may have done a distal subtotal gastrectomy, and there is a leftover portion in the upper portion. And however, there in the follow-up PET, they have found a focal FDG uptake in this upper portion, like near the cardia. However, after the distension, using like water distension, they found that this focal activity disappeared, and they concluded as a it is a just not a recurrence. And actually, it came out to be just a normal, no evidence of the recurrence. Compared to that, like in this case, there has been a focal uptake, and at the delayed image, this focal uptake remained in the same place. So they could conclude that it can be a recurrence. And from the EGD correlation, it also came out to be the recurrence. So this gastric distension, not only for the T staging, but also for like when you want to see the recurrence, it can help. But however, as you can see the same table, you can find out there was one case of false negative, which has been added when doing the delayed image. So this is the case. Actually, so before the distension, they have found this focal uptake in the upper side, which is quite same as the first case. And after the gastric distension, actually this uptake disappeared. However, what came out actually was that this recurrence was, this cancer was the primary. Before the recurrence, actually this tumor had a sigmoid ring cell adenocarcinoma. And actually the EGD finding was also a recurrence. So you need to always think that when you also, not only for like staging, for evaluation of the recurrence of the gastric tumor, this characteristics of the primary tumor is should always be considered to actually to not have this kind of false negative reading. Okay, so as told that this after the distal so tumor characteristics should be considered, and if when you evaluate the recurrence, you always have to review if it is available, it is good to review the initial PET-CT to check the SUV uptake of the primary tumor is important. Okay, and moving on for the response evaluation, I think we had like 1 hour of lecture, so I think we can have some break of 10 minutes. And if you have any questions or comments in between, I think I can answer to the questions. Do you have any questions or comments?
Thank you, Dr. Su.
Oh, hello, Dr. Andra.
Nice to see you again.
Nice to see you again.
Thank you for your nice lecture. I have one question.
Okay.
How do you differentiate between mesenterial seeding or is it mesenterial lymph nodes?
Oh, lymph nodes and seeding.
Yes.
Oh, yeah, actually, it is not. It might be quite hard in some case, like if there is a very nodular only. So seeding also can be can form as a nodular lesion. However, usually the lymph nodes metastasis follow the vessel, regional draining vessel. So it may be more relevant to find these lymph nodes along the vessel. However, for the metastasis, it is not normally following the vessel territories, but they can disseminate and also there might be more chance to see corresponding infiltrative lesions along these nodular lesions. So in that case, it might be better to indicate it as a seeding lesions rather than a mesenteric lymph node metastasis.
Okay, thank you very much, Professor.
Hello. Can you hear me?
Yes.
My name is Wasit. I'm from Thailand. I have a question about the gastric distension protocol you mentioned.
Okay.
So the protocol is like the give the water to the patient. Is that right?
Yeah. So actually, the protocol differs from like many institutions. For like they can give water or other like distending substances, but like we usually give water, and like we give like 300 milliliter of water. But however, like the protocol is not like fixed protocol. Like in some institutions, they give like 300 to 500 milliliter of water right before the examination. It's what we do actually.
Yeah, because I saw the first case that you mentioned, and it's not like water in the stomach. It's kind of like a lot of distension. I'm not sure if there was an obstruction in this. In the first case, yes.
Actually, yeah, it was a obstruction in the stomach, and like food was in the stomach right at when we done the FDG PET for the first case. So not the water, as you have mentioned.
Oh, okay. So I have another question. If do you have like a theory or a science behind that why the poorly differentiation of the gastric cancer does not uptake the FDG?
Oh, sorry. So for the poorly, yeah.
Yeah. Do you have the theory or the science behind why the poorly differentiation of the gastric cancer does not uptake the FDG?
Oh, so yeah. So usually for like most of the cancers, like actually it is known for like compared to the moderately differentiated cancer, carcinomas, it has like less expression of GLUT, or so GLUT expression. So actually, not only for the stomach cancer, but like for like many cancers, when it goes to the poorly differentiated carcinoma, actually in many cases, it is known that SUV drops when it goes to the like poorly differentiation.
Okay, so they lost the GLUT one, right?
Yeah, it might be the cause, or it might be the consequence after the differentiation.
Okay,
Yeah.
okay.
Yeah.
Thank you.
Yeah. Okay, if you don't have any more questions, I think we can have a 10-minute break, and yeah, like let's meet 10 minutes later. Thank you very much. Okay, I think it is time. So yeah, we can go on for. Okay, so we have seen the some roles of FDG PET in tumor staging, and like for nodal staging or metastatic lesion staging, and also its role for detection of the tumor recurrence. Also, some recently studies have focused on whether these FDG PET can be used for the response evaluation. So compared with the CT treatment, so actually on CT, treatment response may be underestimated, although it is the gold standard like RECIST. So like treatment-related changes such as fibrosis, necrosis, inflammation, and edema can see, and since metabolic changes in glucose can precede the morphologic change, Fdg can be an early and sensitive marker for tumor response after the treatment. And usually the criterion that used for the response is that like you can refer to the PERSIST. So like you can see 35% of decrease in the initial SUVs can be in many studies are referred as a responder. So when dividing the patient into the responder and non-responder group, they have seen a significant survival improvement in the metastatic responder. So which means that this FDG, using the FDG can be a good indicator for the treatment response. One more thing that I would like to share is about HER2. So there has been a adaptation of treatment algorithm for the advanced gastric cancer. So now the HER2 testing is important because when for the HER2 positive gastric cancer patient, the trastuzumab, which is the HER2 targeted therapy, has been applied as a first-line drug. So it is important. The HER2 positive or negative is important. However, there has been not that much study to show the relevance between the HER2 positivity and the FDG PET-CT, so the glucose metabolism. So there one study in 2016 reported that the SUV value, according to the HER2 stages, that when like there is a relationship between the HER2 positivity and the SUV value, and at the HER2 positive has significantly higher SUV max compared to the HER2 negative. And also like by the Ajcc grade, there was a increasing relationship. However, there is a debate according whether the HER2 has, if not treating with the trastuzumab, like HER2 targeted drug, whether HER2 itself is a prognostic factor in the gastric cancer. So actually it is not well known, but as you can see in this study, they have shown that when only analyzing the patient who have underwent systemic chemotherapy without the HER2 targeted therapy, HER2 positivity itself did not was not differ for the survival. However, like the metabolic parameter SUV had a significant difference among the high and low group for the survival. So like for the patient who has a higher SUV value had a probability of low survival in this study. And actually it was also, like as you can see here, regardless of the HER2 positivity, this metabolic parameter, the SUV, was related with the overall survival. So like you can imagine that the higher primary tumor with higher SUV value in this study showed a low survival. So, however, there still is a lack of study regarding the relevance between this HER2 and the how the glucose metabolism is relevant and what might be the role in such a case, whether this FDG PET can indicate or characterize the patient for the HER2 targeted therapy. It should be, can be further evaluated in more studies. Okay, so we can move on to the colon cancer. So colon cancer is in male third and for female second most diagnosed malignancy worldwide. And colorectal cancer accounts for approximately 10% of cancer-related deaths worldwide. And as you can see, incidence is high among the developed countries. But however, due to change in habits, like life habitat, the incidence is increasing. Before starting, we need to know the anatomy of the colon itself. So actually, it is known that the right side and the left side has a difference. So like for the transverse colon, it is just arbitrarily like 2/3 of are considered right side. But from the studies, it have shown that prognosis is differ, and overall, the prognosis is being worse in the right-sided colon cancer. And and the right side tumors, you can see has a more chance of being microsatellite instability high, and may have relative resistance to the chemotherapy. However, like because these right-sided tumors have a high chance of microsatellite instability, right now it may have more chance to have a immunotherapy. So therefore, like future outcome for these right-sided tumor may change, but right now in this state, you can just you may easily refer that right-sided tumor as like worse prognosis. So for like studies for MSI status for like prognosis, the location of the tumor also should be considered when you do the retrospective study, like when you want to see a prognostic parameter from the FDG PET. This location of the tumor should also be a variant that should be considered. Okay, so the T staging and like nodal staging actually is similar to the gastric cancer. And as you can see, like T1 is tumor that invades the mucosa, and T2 is muscle layer, and T3, which is through the invade through the muscularis propria and into the pericollector tissue. And as you can see from the CT image, this T2 can be shown as a well-defined peripheral wall with clear adjacent fats. And for T3, it can be shown as a poorly defined peripheral wall, and also pericolonic fat infiltration can be seen. And for the T4, it is known, T4 is classified into T4A and B, and A is which penetrates to the surface of visceral peritoneum, and B is which directly invades the other organs. But before moving on to T4A, it is actually notable to see there are some portions, like for the ascending and descending colon, mostly, and for the rectum, the posterior part of these colons are actually not enveloped by the peritoneum, but it's actually extra peritoneum. So in such posterior aspects, T4A, because T4A is not applicable, because T4A is as defined whether if there is a tumor penetrate through the visceral peritoneum. And since there is no visceral peritoneum covering this area, this T4A cannot be applicable when the tumor is on the posterior side of this like ascending or descending and rectums. And also MRI is more is readily used for T staging, and it can actually define like T1, T2, and T4, T3, and T4. And for T4B, like direct invasion in other organs includes the organs like left kidney or right abdominal wall or prostate, seminal vesicle, cervix, or vagina. Okay, moving on to the lymph node, it is so for the colon cancer, the primary colon cancer in the different location, the regional lymph node is different, as you can see in the table. So like for more specifically, as you will be well informed about the regional lymph nodes of the anal cancer and the rectal cancer is significantly different. Like for inguinal node are regional lymph nodes for the anal cancer, but for the rectal cancer, it is not, and it is actually considered as not a regional. And also for the rectal cancer, the superior or middle rectal or inferior mesenteric can be considered as a regional lymph node metastasis. However, not for the anal cancer. And like other lymph node metastasis to the femoral lymph node or common iliac or external iliac or para-aortic can be considered as a distant metastasis. I have not actually put a slide in here, but recently there has a profound work using the multi-omics of the tumor and lymph node and metastatic cell lines. And right now, there is a consensus that for the colorectal cancer, like distant metastasis can be seen without a regional lymph node metastasis. So like previously, like normally we think that distant metastasis starts from after the regional lymph node metastasis. But for like colorectal cancer, they have found some traits that there can be a skip of metastasis. So you can just keep that in mind. So without a regional lymph node metastasis, you may encounter with some distant lymph node metastasis or distant like liver or lung metastasis can be seen. And similarly to the stomach cancer, this end staging is considered according to the number of the regional lymph nodes. So like lymph nodes less than 3 can be considered as N1 as in this case. And this is the brief summary of the 8th edition of the Ajcc. And actually, there has been not that much change from the previous 7th edition. And for the treatment algorithm, it can be quite confused. So actually, like for stage 0 to 2, 3, or it might be easy because like surgery can be done in these cases. However, like indifferent from other tumors, for treatment of the metastatic, like in case of stage 4, it differs because like treatment of liver metastasis there is option of surgery or neoadjuvant chemotherapy or local ablation or systemic chemotherapy can all be an option. Also, like yttrium therapy can be one option. And like treatment also for other stage 4 and recurrent colon cancer, like there also surgery can be applied. So the exact extent to actually the single most prognostic indicator of this colorectal carcinoma is to adequately evaluate the extent of the tumor at the time of diagnosis, because it can really significantly differ the strategy for the patient treatment. And again, for the resectable, like as you have seen, there is an option for, although there is a distant metastasis, for the liver, there is an option of surgery. And when you can move on to the surgery, there is a significant gain in the survival. So, but there is some criteria which to define the resectable hepatic metastasis, which is like when there is a limited number of lesions, and if the intrahepatic location and the location of lesion, like if the lesions are in the both sides of the lobes, it might be hard to do, and it should actually preserve at least 2 segments of the liver. So like, and also there should be a absence or limited extrahepatic disease. And like for this actually is important because there is a role to, like when there is a hepatic metastasis, the Fdg PET has a role to actually find other extrahepatic disease. And it might significantly change the patient treatment strategy. And actually also there is a option of surgery at the recurrence. So for the locally recurrent tumor, it can be resected. And if there is like liver only or lung only metastasis, metastectomy can be done for these lesions. And it has shown a gain of survival against just applying the systemic chemotherapy. So FDG PET, we can apply FDG PET for colon cancer evaluation. But before, we also need to know the Fdg uptake pattern in these bowel colon according to the anatomy. And usually it is interesting that usually the physiologic uptake of the colon is mostly higher in the ascending, like in the right side of the colon is higher than the distal part. But there are other like conditions that may significantly increase the bowel uptake, which is when for the type 2 diabetes patient, when they are applying metformin, this metformin can actually increase the FDG uptake in the bowel. And the mechanism actually is not clear, but it is known that this metformin can increase the glucose metabolism in the enterocyte. So the cells in the colonic cells, metabolism of glucose increase. So like FDG uptake may increase is one of the hypotheses. So when you read this colon, like for evaluation of colon cancer, these physiologic uptake should be always considered. And also, like you may encounter a but before moving on, because there is a diffuse uptake caused by the metformin, there has been a study how to reduce this metformin uptake. And as reviewing the studies, I have so still there is a debate. So how long the time point will be relevant to reduce the metformin-induced bowel uptake? So one study have shown that in this study, like 48 hours, if you stop 48 hours before the FDG PET-CT, the metformin-induced SUV increase can be reduced. However, some studies indicated it is needed, like 72 hours is needed. But another, like from the other hospitals, said shown that although we stop for 72 hours, there is like no significant change. So it seems still some debate, but we can, if it is possible, it may be better to stop this metformin. Specifically, if we want to evaluate a tumorous lesion in the colon, it might be better to stop. So regardless of these kind of diffuse uptake, when we interpret the FDG PET, because like for other like lung cancers or breast cancers, we may encounter its focal colonic uptake. So there has been studies about what is this characteristics of this incidental colonic uptake. And as you can see, like these, we can normally see a diffuse uptake along the colonic wall, especially as shown like in the ascending colon. However, it is not that much normal to see a focal uptake. And this, when evaluating this focal uptake, this study indicated that most were actually a tumorous condition, including like adenoma and also the adenocarcinoma. And in this study, they have shown that adenoma, like Billow's tubular type, which is high-grade dysplasia and also like precancerous lesion of adenoma or adenocarcinoma, had higher SUV max value compared to the just benign adenoma or poorly differentiated adenocarcinoma. And yeah, and also you can see that compared to the diffuse uptake, the focal uptake may indicate a tumorous lesion. However, like diffuse uptake, they can also be a tumorous lesion. However, there was no finding of a malignant lesion for the diffuse uptake. So from referring to the study, we can actually more focus on the this kind of focal uptake lesions. So there has been a study to evaluate like more than 7,000 patients, and they found like 5% of focal colonic incidental colonic uptake. And from this 5% of patients, what they have found was that actually like more than 60% of patients were had a including the inflammation, some benign or malignant condition, and like 38% had a no abnormality. And also their study have shown that compared to the like benign condition, the colon carcinoma had the highest SUV max. And it is quite, because it had a more number of patients, it might made a difference compared to the previous study. But it can be known that usually the carcinoma has a higher uptake than the benign lesion, and also like pre-cancerous lesions such as advanced adenoma, like below tubular type adenoma, has more higher uptake compared to the benign lesions. So the incidence of this kind of incidental colonic uptake finding differs from the studies, but it has a range of 3 to 5%. And sensitivity to find it as a true lesion, sensitivity is 86%, and positive predictive value is 32%. So we can conclude that if you see a incidental focal colonic uptake, it is better to recommend colonoscopy, because there is a high chance of at least benign polypoid lesion. So, and as you can see, although the incidence is low because of high sensitivity, it is better to recommend colonoscopy when you encounter with this focal uptake. Okay, then moving on to the workup of real colon cancer. In the NCCN guideline, PET-CT is not routinely indicated for the workup, but it can be considered as if potentially like as I mentioned, in surgically curable M1 disease to find out whether there is a extrahepatic metastasis, or in selection of patient considered for image-guided liver-directed therapy, which is also to find out extrahepatic metastasis. So the first, the case is a male patient with 38-year-old male patient, which was biopsy confirmed as a adenocarcinoma from the outside colonoscopy, and has done a evaluation. And as you can see from the MIP image, there is a uptake in the, we can assume in the like splenic flexure, and some focal, also another uptake in the mid side of the abdomen. And when you see the transverse image, you may find out there is a thickening, and there is a focal hypermetabolism in the distal transverse colon, the splenic flexure and a focal hypometabolic lymph node in the mesenteric area. So this patient underwent subtotal colectomy, and it came out to be adenocarcinoma, which is poorly differentiated, and it penetrated to the surface of visceral peritoneum. And the lymph node, the mesenteric lymph node, came out to be positive. So the patient was diagnosed as T4 and 1. And the next case is 55-year-old male patient who had a hematochezia and abdominal pain. And this patient also underwent a colonoscopy and was diagnosed as a cancer, adenocarcinoma. So patient underwent a Fdg PET for the staging workup. And as you can see in the MIP image, there are some lesions, maybe in the sigmoid colon area and some mid focal uptake. So looking at the transverse image, you might see a small mild hypometabolic lesion in the para-aortic area and a thickening with a hypermetabolism in the sigmoid, which involved the sigmoid colon. And it is hard to differentiate from the PET-CT, however, some small regional lymph nodes. But actually, there is some more if you look closer, like, because it is just you may find a focal uptake also in the lung field. And also there was a lesion in the liver. So like in the S4 liver segment, you can see a focal hypometabolism in the liver. And also in the lung view, you can see a focal hypometabolic nodule in the right upper lobe. So actually, just doing the and from the liver MRI, this patient was shown to have a liver metastasis. So, but this additional Fdg PET can actually find out the patient has a additional lung metastasis. And one more thing is that for the liver metastasis, it might be hard in some cases because of the movement of the diaphragm movement, or because of the normal liver uptake. It might be hard to discriminate the focal metastatic uptake in the liver. So always referring the PET only image can also help indicate such a focal lesions. And also, interestingly, there was a very nodular lesion in the rectum. But however, in the PET, they have shown a not very high, very low metabolism. So we concluded so for this case, we concluded that the patient had a sigmoid colon cancer with liver and lung metastasis. And this rectal mass is another like secondary primary with low FDG or benign tumorous condition. So this patient underwent sigmoid colon anterior resection and found out as a adenocarcinoma. And also liver tumorectomy was done and found as a metastatic adenocarcinoma. And for the rectal mass, it was actually a benign lesion of leiomyoma. And the next case is a 42-year-old female patient who had lower abdominal pain 6 months ago and underwent female patient. This was a female patient. And as you can see, there is a hypermetabolism in the, sorry to change the direction. And this is the right side, actually. It is the posterior of the MIP view. So there is a ascending colon cancer. And actually, interesting finding was there was a bilateral cystic mass and some hypometabolism involving this ovarian hypometabolism in this ovarian mass. And also some retroperitoneal lymph node was seen, and also liver metastasis was visualized. So we concluded this patient as a ascending colon cancer with a liver lymph node and liver and bilateral ovarian metastasis. And also, as expected, after the right hemicolectomy, it was shown to be adenocarcinoma with small bowel invasion. And after the bilateral salpingo-oophorectomy, it was confirmed as metastatic adenocarcinoma in the bilateral side. So for the staging of the use of the Fdg PET-CT actually is quite limited for the T stage or nodal staging. And CT or MRI is readily used for T or N staging. However, there is a indication recommendation for PET to find extrahepatic metastasis. And also, like from the previous studies, it is known that when you do this Fdg PET-CT, there is more like higher diagnostic accuracy compared with the conventional CT or MRI. And it can actually lead to upstaging, and we can avoid unnecessary surgery in 20 or 40 patients when we do such a Fdg PET. And also for the lung metastasis, it has shown that it has a higher diagnostic accuracy compared to the contrast enhanced CT. Yeah, so the detection was higher than the contrast enhanced CT. And another point is about the ovarian metastasis in the female patient is, as we have seen from the case, there is an incidence of like 4 to 8% of ovarian metastasis. So, and the origin of the primary tumor are more frequently found in the ascending colon, followed by rectal sigmoid colon and other side of the colon. But mostly in the ascending and rectal sigmoid colon. And it is interesting that in most of case of the ovarian metastasis, the bilateral ovary are actually involved. And relevance to the such ovarian metastasis can be actually referred from the this kind of peritoneal connection. So there is some interconnection between the right-sided colon with the pelvic cavity. And so there is a connection between this, there is more chance of this right-sided colonic cancer, especially the Seok cancer, to have a metastasis or invasion to the ovary. as we have actually seen from the case. The NCCN actually recommend a consideration of preoperative PET-CT scan baseline in selected cases if prior anatomic imaging indicates the presence like potential surgically curable M1 disease. And if we want to find out like extrahepatic disease, this Fdg PET is recommended. Next case is in the scenario of the recurrence evaluation. And so 83-year-old male patient who had a sigmoid colon cancer and who underwent laparoscopic anterior resection 3 years ago had a follow-up of CEA, and recently he had found out a increase in the CEA level. So to find out the reason for this increasing CEA level, the patient underwent firstly the CT scan. Sorry, but however, you might have some time to review the scan, but there was no, in the formal reading of the CT, abdominal CT scan, firstly, there were no significant lesion to demonstrate a tumor recurrence or distant metastasis. However, when you see the Fdg PET-CT, which was done after, oh, sorry, I think I have, okay, sorry, I think the video is not containing all the image. I really apologize. I will just, I would like to visually indicate that in the, near this anastomosis site, although not significant in the CT, in the Fdg PET, there was a significant Fdg uptake. So the colonoscopy was done to confirm whether there is a recurrence and find out there was a tumor recurrence. And the patient underwent, again, a colon sigmoid anterior resection and also find out to have a recurred adenocarcinoma, and with say involvement of like small intestine, ureter, and common iliac artery lymph node. So as you can see, for the recurrence evaluation, PET-CT has high sensitivity and specificity. And specifically in the setting of like in the CEA, when there is a CEA rising, and also like although like from the conventional imaging it is negative, there has a high chance of finding a recurred lesion. And pooled sensitivity and specificity from this meta-analysis was 94.1% and 77.2% respectively. So use of PET-CT scan in the situation of CEA rising, and when there is a negative finding in the conventional imaging, the PET-CT is recommended in the NCCN guideline. And there are some pitfalls that you need to consider when interpreting the like tumor staging or tumor recurrence. So there can be a false negative according to the tumor characteristics, like in the which we have discussed in the gastric cancer, like mucinous carcinoma, or like for gastric cancer, diffuse type, poorly cohesive or signaling ring cell type may show as false negative. And for the colon cancer, also mucinous adenocarcinoma has shown that it has a lower Fdg uptake compared to other adenocarcinoma. And like patient with glucose intolerance or diabetes using metformin can also hide the real lesion, which in turn show as a false negative. And also there are some causes of false positive, like infectious inflammatory process, especially after the radiation and surgeries. So like it is in some studies, it is recommended like for after post biopsy 1 week and post surgery 6 weeks, and like for ERT like 4 to 6 months is recommended for the FDG study to actually not to encounter these false positive results. Okay, so for the take-home message, I would like to again inform that for the gastric cancer, this gastric distension strategy may help the diagnosis of not only the staging or for the recurrence evaluation, and the tumor histologic characteristics should be considered when you evaluate the tumor, and also to find the recurred lesion. And especially to find the recurred lesion, it is important to refer to the initial PET-CT if it is available to see the FDG ability of the primary tumor. And for the colon cancer NCCN guideline, FDG PET-CT is recommended in the initial staging for suspected metastasis, and when the other imagings are not that much indicative, or restaging before curative treatment of the hepatic metastasis to find other extrahepatic metastasis. And in the situation of suspicion of recurrence, like if there is a rising of serum CEA, but the conventional imaging is negative, FDG PET can give additional information. And also, if you see when you evaluate like for PET-CT, if you see a incidental focal colonic uptake, it is better to recommend a colonoscopy because there is a high chance to find a precancerous or malignant tumorous lesion. Okay, thank you very much. This is the end of my presentation, and I would like to give thanks to our colleagues, Dr. Vanessa and Dr. Kong and Dr. Lasna Tiwari, to actually share their information and cases. So, and thank you very much. And if you have any questions or comments, please ask, or if you have comments, please give us some comments. Oh, sorry. Okay, thank you very much. So if there is no extra questions or comments, I think we can end this session now. And before, please, I would appreciate it if you could fill out the questionnaires, and if you can leave some comments at the questionnaires, we can actually more update some contents for your favor. And one more thing that I want to inform is that because of some circumstance of Professor Hyungjun Im, actually the scheduled lecture next week is from Hyungjun Im, professor. However, it will be changed. And next week we will discuss, I will be the lecturer, and I will discuss about the male genitourinary cancer. So see you next week, and thank you very much.